Just for review, metabolic syndrome, as you know, is a combination of factors: abdominal obesity, high triglycerides, low HDL, high blood pressure, and impaired fasting glucose or diabetes. But making the diagnosis of metabolic syndrome in the setting of an acute MI is difficult because the factors that comprise the metabolic syndrome are believed to be altered in the setting of an acute MI. But is making the diagnosis important and even reliable? That's the question. The answer: important, absolutely. Reliable, probably. Now in JACC, researchers report on a multi-center registry for metabolic factors at baseline and 1 month post-acute MI and followed patients for mortality and rehospitalization. The accuracy of an inpatient diagnosis of metabolic syndrome was calculated using a 1-month follow-up as the gold standard. Patients were also categorized based on diagnosis at baseline and at 1 month, and the combined endpoint of death or rehospitalization over 12 months was compared between the groups. Here are the findings. If a patient had the diagnosis of metabolic syndrome made during the acute hospitalization, the chances were 11-fold higher that the same diagnosis could be made at 1 month follow-up. That's pretty reliable. But the most important finding was the prognostic value of having the diagnosis. Patients without a diagnosis in the acute setting or at 1 month did the best long-term. Patients who had the diagnosis made at the acute setting but not at follow-up did worse, but here's the most important item: patients with the diagnosis made at the acute setting and also in follow-up had the worst outcomes. What's the take-home message? In a large cohort of acute MI patients, the diagnosis of metabolic syndrome is common and can be made with reasonable accuracy during the acute phase. It is associated with poor outcomes, regardless of whether the diagnosis is confirmed during subsequent outpatient visit, and identifies a high-risk cohort of patients that may benefit from more aggressive risk factor modification. That's something we can treat. I'm Peter Block for CardioSource.